Thank you very much, Annette. So the question is whether we should be doing without prescriptions, and the answer to that is absolutely yes, not just in the Asia Pacific, but globally. And the reason for that is PrEP uptake, particularly in Asia Pacific, is expanding, and we can see that on this slide here, particularly in countries like Australia, Thailand, Vietnam, and Philippines, which have done particularly well over the past couple of years. But a lot of other countries in the Asia Pacific lag behind, including Malaysia, Myanmar, and are slow in terms of uptake. And if we want to impact on HIV incidence, we need to do much, much better. So this slide was shown by Heather Marie earlier this morning. If you look at countries in the Asia Pacific, we compare very low compared to other geographical regions within the world. And look at where our targets, that's the chart on the right, 2025 targets of 4 million, but we're tiny compared to other parts in the world. So we need to do more in terms of PrEP initiations. And what we have done, in our attempt to try and keep patients safe from HIV infection, we have ultimately over-medicalized PrEP. And this is an example from a PrEP demonstration project that I was involved in a couple of years ago. And you can look at it and look at the sheer number of tests that are required and the frequency of testing. We have done an injustice in many ways by over-medicalizing PrEP. And really it's trying to find that essential balance between what keeps the patient safe with HIV testing as a bare minimum and PrEP dispensing and all the other tests that are required to enroll patients in a PrEP program. So if we want to do better, if we want to get our act better, if we want to scale up, we need to make our services simpler. And that's also recently recommended in WHO guidance in their recommendations in July 2022. We need to, and we've heard this a million times already, we need to make our services community-centered, person-centered. We need to adapt our services to needs and preferences of users. And ultimately, the aim is to improve uptake and persistence and effective use. So why demedicalize PrEP? Now, doing away with prescriptions ultimately is the extreme end of demedicalizations. Doctors in many ways, and I'm speaking as a doctor, have been barriers to the rolling out of drugs which are not too complicated. And PrEP is so easy. And in almost all settings in Asia, it requires prior authorization by a clinician. But this is not rocket science. It does not need to be done by specialists, let alone a doctor. It's straightforward, minimal complexity, and it's very much guideline and protocol driven. So what's so difficult about it, and why are we making it so difficult? Most PrEP users are young, they're healthy, no comorbidities, men, which we know find it very difficult to navigate and access care, and they can manage their own health. But many people find it difficult to navigate our very complicated health systems, and hospitals prioritize curative over preventive interventions. They have limited operating hours, they're not flexible, there are concerns around lack of privacy, there's lack of sensitization to key populations, and the list goes on. And it's incredibly safe. Oral PrEP has an incredibly safe record as shown, safe track record as shown by here. Yes, it is associated with a 49% increase in grade 1 adverse events, but not grade 2. And for those who have had longitudinal follow-up, we can predict those who are likely to develop associated issues with kidney function. So the older you are and those with a baseline creatinine clearance of less than 90, these are the ones that we want to focus most of our safety measures on. But the majority of people, we are probably being just way too much safe. And this has been reflected in the updated WHO guidance, and also the WHO guidance recently has made and become more permissive around HIV self-testing. So that's the way forward. We should become more permissive rather than restrictive. PrEP stigma remains a big barrier to access of PrEP, and this is recently examples from my own country, Malaysia, when the Ministry of Health, after many years, decided to roll out PrEP from the public sector, which was a fantastic thing with financial assistance from the Global Fund. But there was huge pushback from religious academics, religious leaders, and religious healthcare professionals. And healthcare professionals were who had religious ideologies were one of the biggest barriers preventing the rollout of PrEP. Fortunately, this has moved on, and Ministry of Health have decided to go ahead, and we're very lucky. But navigating those HIV prevention policies in countries where you have Islam in particular, it can be very, very difficult. And clinicians are not any better. And this is a feeling thermometer from medical students and dental students, so the future clinicians in our country from 8 professional schools, asking how they felt about certain key populations. Most discriminated against MSM, more so than people who inject drugs, and then followed by HIV-positive patients. We've heard from Nitaya that this stigma problem just continues, and we really need to try and do more, but what do we do? The US is already leading by examples. California has already become the first state, and other states in the US have followed through to allow PrEP to be sold over the counter without prescriptions. Pharmacists are ideally placed because they are able to address preventative health needs such as contraception. So I say just follow contraception. They're convenient, they have shorter waiting times. They're not meant to replace primary care. They are a doorway to primary care for people who are not accessing care. But they require strong collaborations with physicians and CBOs. So we're not just saying let PrEP go wild. And pharmacy-led models in Kenya, pilot studies have shown that pharmacists who have been given prior authorization to prescribe PrEP do it well. They're able to do it very well and deliver high-quality services which are acceptable to the key populations they're trying to serve, as long as there is the essential components of a PrEP service delivery are met. And they include testing, counseling, prescribing, and dispensing, but with remote clinician oversight. But really, we should be trying to take the doctor out of the equation. Thailand and Vietnam, and also the Philippines, has had incredible successes with key population-led health services, and very unfortunate what's happened recently. We need to learn from that, not regress. Key population-led services are clearly needs-based, they're client-centered, and they're staffed by members of key populations. They tick all the check boxes. So the one thing that I have learned from this is let the communities guide us, and maybe just take the doctor a bit out of the equation eventually, but with remote clinician oversight. Once again, PrEP is not complicated. And Thailand has been able to show that. As we know, 80% of users obtain PrEP from key population-led services. Let's not re-medicalize PrEP. But what we must continue in demedicalized models of care. So even if we do away with prescriptions, it doesn't mean doing away with everything else. We need clear protocols, we need clear guidelines to those delivering PrEP. We need to establish strong linkages and partnerships with other services, including physicians, for oversight and referrals. We need to ensure that those delivering PrEP have ongoing training and professional development, and clearly, as shown in Thailand, accreditation and certification of these services. Just because you do away with a prescription does not mean you're doing away with these services. And integration of other services. Dispensing PrEP in pharmacies is an opportunity to also scale up HIV self-testing in pharmacies. And most of all, reimbursement. And let's not forget other potential benefits of demedicalization. It supports client care, tick box. It allows physicians to concentrate on more complicated cases, which is essentially what we're there for. It diversifies services, allowing patient choice. It builds partnerships between different services, and it builds capacity. And clearly in key population-led organizations, it's built capacity of a huge workforce there. And ultimately, we're talking about increasing accessibility, increasing uptake, and retention, ultimately. So really, I'd just like to conclude, and I hope my opponent will wholly agree with me, because I know you will. The availability of PrEP without a prescription, above all, is a call for action, for self-empowerment, and everyone to take control over their sexual health. We do not need a doctor to tell us to do that. I'm sure I can entrust most people to be able to do that. We want to empower individuals who may not have access to health care or who may not feel comfortable talking about sexual histories to their doctors. That is understandable. We want people to empower themselves to be able to manage their own health needs. And in the context of health, this is already gaining prominence in the management of many chronic diseases. So with that, and I think I've improved on time compared to my last debate, so I'd like to end there, and I'd like to give my opponent the platform to go against me. Thank you very much.